audio is by telephone only, and the webinar today is being recorded. It's going to be available about 2 to 3, sometime this week or next week for those who cannot attend today's presentation. For those of you following by telephone only, you should have received a backup PowerPoint, so we'll make sure that we indicate the slide number as we go through today's conversation. For those of you who are on Adobe Connect, thank you so much for joining us. You can use the chat box at any time during the course of today's webinar to ask questions, share resources, and have conversations with our presenters. My colleagues and I will be keeping track of the chat box and will be drawing on your questions during the question and answer period. I can see that a number of you are already introducing yourselves in the chat box. If you haven't already done so, please let us know your name and where you're calling in from. If you are calling in with a group, please do let us know that also. We're now on slide number 3. As I mentioned, my name is Sumenjumbe Ayo, and I am a Knowledge Translation Specialist with the National Collaborative Center for Determinants of Health. I'm also joined today with my colleague Val Morrison, who's a Research Officer with the National Collaborative Center for Healthy Public Policy, and both our centers are bringing you today's webinar. We're now on slide 4. We are very pleased to be joined today by 3 speakers. So you'll see 4 speakers. Unfortunately, one of our speakers is not able to join us today because she's not feeling well. We're joined today by Sami Asti, Natalie Clark, and Ruth Cameron, who I'll introduce in a more fulsome manner shortly. We're now on slide 5. As you introduce yourself, let's get a sense of who is calling in. This webinar has received a lot of interest. By my last count, we had over 300 people register. So we have a poll going up now on slide number 5. We'd like to get a sense of what part of the country do you work in? Excellent. So I see here we have lots of people calling in today from Ontario. Welcome. Lots of folks calling in from BC. I can see some Alberta, Saskatchewan, Manitoba, the territories, excellent. The U.S., we did have a registration from Egypt, so glad to have you all here today. Thanks, Anna. So moving on to slide number 6. As I mentioned, today's webinar has been hosted by the National Collaborative Center for Determinants of Health and the National Collaborative Center for Healthy Public Policy. Our 2 centers make up two of 6 centers which make up the National Collaborative Centers for Public Health in Canada. All NCCs are funded by the Public Health Agency of Canada, and our mandate is really to support public health programs and policies across the country by paying specific attention to increasing awareness of new and existing knowledge. All centers have a topical focus, so in addition to our 2 centers, we also have centers focused on Aboriginal health, environmental health, infectious diseases, and methods and tools for knowledge translation and evidence-informed decision-making. And we collaborate with with all of you on the phone to really support your work in the various areas. So a little bit about the NCCDH. We're now on slide number 7. Our particular mandate at the NCCDH is really to support work related to the social determinants of health and health equity, and working specifically with stakeholders in the public health sector. I'm now going to pass it on to Val on slide 8, who will tell us a little bit about the National Collaborative Center for Healthy Public Policy.
Hi everyone, thanks for being with us today. Our mandate at the National Collaborating Center for Healthy Public Policy is to support public health actors in Canada in their efforts to promote healthy public policies. And by healthy public policies, we mean policies that come from sectors other than health and which affect the health of populations. So we do this by providing support in various areas, such as learning the effects of public policies on health, generating and using knowledge about policies, intersectoral actors and mechanisms, as well as developing strategies to influence policymaking. Our offices are located in Quebec and Montreal, and our institutional host is the Institut National de Santé Publique du Québec, that is Quebec's National Public Health Institute. Thanks again for joining us, and back to you, Sami, to get to the heart of the webinar.
Great, thanks, Al. So before we get started, some of you may have filled out this question when you registered. We have a poll up on slide number 9, which Anna's going to open up here for us. And I want to get a sense of how familiar are you with the concept of intersectionality. You have 5 options to choose from, ranging from not at all familiar to extremely familiar. Great, excellent. So we have responses coming in here. We're going to leave the poll open for a few more seconds. Okay, so we have about 37% of people that chipped in saying they're slightly familiar, about 30% saying moderately familiar, about 15% not at all, and a few people on here are extremely familiar with intersectionality. Great, thank you. Thanks, Anna. Okay, we're now on slide number 10. So it's clear from our last poll that today we have a range of experiences on the call. In preparing for today's webinar, we're really framing it as an introduction to the concept of intersectionality with an acknowledgement that we're all coming into today's conversation from very different positions, both in terms of knowledge and in terms of how we use and apply intersectionality in our work. Our presenters today will be discussing their understanding of intersectionality and paying particular attention to how intersectionality can be used in public health, in a range of public health contexts, so policy, practice, and research, and also really focusing on how intersectionality can help us advance our work related to health equity. We're now on slide 11. Our format for today is going to be a dialogue-based approach. Our presenters have a series of questions which they received in advance, and I'm going to be responding to those today. I'll encourage you to use the chat box throughout to send in your questions, so if there's anything which comes up which you'd like our presenters to delve into in more depth, please send that in via the chat. Also, just in terms of language, we're talking about health, and we're using health in a fairly broad and holistic sense. So thinking about health in its social, political, cultural, and economic context. Also on language, our presenters are going to use whatever language is most comfortable to them. And so if you need some clarity there, please do ask us to do so. We will be using health equity, health inequalities in a fairly interchangeable manner. And when we do so, we are referring to differences in health which are systematic, avoidable, and thus unfair. So moving now to slide number 12. I am going to get us started just doing a very quick introduction on intersectionality. I'm not going to go into a lot of depth because I'd like our presenters to do that. And so for the next couple of slides, we'd like to frame why our centers are actually hosting today's conversation. We're now on slide 13. So in the previous slide, I think when I think about definitions of intersectionality, I love that quote from Audre Lorde, who says, "There is no such thing as a single issue struggle because we do not live single issue lives." So what exactly did she mean by that? So when we talk about intersectionality, we're really talking about how we look at individuals, communities, and societal problems in a way which is complex and dynamic, and acknowledging that we do not live single-issue lives. So individuals and communities are multifaceted in terms of race, gender, income, and those tend to be the holy grails of intersectionality over the years. It's expanded beyond those three categories. We're really thinking about how individual and community experience is created and interacts with a range of systems of power. So so not looking at a single factor. The term intersectionality itself was first used in the late 80s by Kimberly Crenshaw, who was speaking about the experiences of Black women, particularly in the legal system, and discussing the ways in which both gender and race were having very specific impacts on the experiences of Black women. As an idea, it's generally rooted in a range of feminism, so Black, Indigenous, post-colonial, anti-colonial, and queer feminisms. A lot of people will tell you that intersectionality, before it was called that, has been around for a very long time. We can think back to Sojourner Truth, who in 1851, in Ain't I a Woman, asked that question about her unique experiences as an African woman born into slavery who died a free woman. So she was in the 1800s. She was speaking about how her particular experiences were not necessarily being represented in the conversations going on related to women's rights, which was at that point really focused on the rights of white women, and also in anti-slavery movements where the female experience was not being highlighted. So she was really bringing in that sense of multiplicity in our approaches. Now we're off to slide number 14. So why do we need to think about intersectionality when we're having conversations related to health equity? I think, as I mentioned, intersectionality really highlights the fact that single identities did not adequately explain the intricacies of human life. I often think about intersectionality as both a political and analytical project, and it can really help us have a better understanding of how various systems are connected and how these shape very unique experiences for different populations. I think intersectionality is one of its strengths is that very explicit focus on systems of power, and that level of analysis allows us to develop a better understanding of the root causes of a wide range of societal issues. And as such, this can be a very useful approach as we look at responding to growing social inequities, particularly as they relate to the social determinants and health equity. We're now on slide number 15. So on slide number 15, we pulled out this chart, which just tells you, so the National Collaborating Center for Healthy Public Policy released a document recently which talked about a range of approaches we can use to reduce health inequalities. So this slide, which is from that document, really shows us how intersectionality can be very useful as we develop a better understanding of how social position, as well as the political, economic, cultural, and social context create differential outcomes for different communities. So I think as an approach, again, intersectionality really helps us focus on the determinants which actually create inequalities and inequities, as opposed to some of the more midstream and downstream determinants. So this is just a really quick intro. We're going to spend the next part of our time together with our presenters as they respond to the various questions. On slide number 16, we have included links to two documents from work which we have done at the NCC for Determinants of Health and Healthy Public Policy, which delve into this area in a lot more detail. So we're now moving into the discussion part of our conversation. At this point, I'd like to introduce our three presenters for today. Our first speaker is Sami Asti, who is a health promotion consultant with Public Health Ontario. Sami Abdi provides training and support services to Ontario's public health and healthcare stakeholders to help them plan and evaluate interventions. She works with the Health Promotion Capacity Building Unit, where she supports program development and implementation with public health units across the country. I know that Samiya's work is really very focused on health equity, and she's been bringing intersectionality into the work she's doing with health units. She holds a Master's of Public Health from the University of Waterloo. Thanks for being with us today. So as I introduce our presenters, you notice that on each of the slides, our presenters have shared very specific resources with you, which you can explore after today's webinar. On slide number 18, our next presenter is Ruth Cameron, who is the Executive Director of the AIDS Committee of Cambridge, Kitchener, Waterloo, and area. Ruth is a doctoral student in community psychology at Wilfrid Laurier University, where she's studying intersectoral population health initiatives. She's a former community-based research facilitator at the Ontario AIDS Network. Her community development experience encompasses work at the East Mississauga Community Health Centre, Rainbow Health Ontario, the Rape Crisis Movement, and Newcomer Settlement. Ruth is a graduate of McMaster University with a Master's of Arts degree in Sociology with a focus on race, class, and gender studies. In 2014, she founded the Audre Lorde Scholarship for Black LGBTQ youth in Hamilton. Our third speaker today is Natalie Clark. Natalie is a violence counselor and associate professor of the Faculty of Education and Social Work at Thompson Rivers University. Natalie's work focuses on trauma-informed practice as well as work with Indigenous families and communities. Natalie continues to practice and provide training on trauma-informed girls groups, including the model she co-developed and co-facilitated for over 12 years in both rural and urban spaces. So our presenters may want to share different aspects of their work with you as we begin today's conversation. We're now on slide number 21. So our very first question to get us started is for our presenters, can you tell us about your understanding of intersectionality and how you use it in our work? We're going to start with Ruth and then go to Natalie and then Samiya. Thank you. And to unmute your line, presenters, it is #6. Off to you, Ruth. Ruth, can you get us started with that first question? To unmute your line, it is #6.
Sorry, I thought I was unmuted. Can you hear me now?
Yes, we can.
Okay, sorry about that. I guess I would start off by saying my understanding of intersectionality is that I consider it a very useful framework when trying to think in a complex way about how both the interaction of identity, experience, and systems of oppression and privilege interact when we are talking about individual and population health. I would say that intersectionality helps us look at paradoxes when it comes to individuals' health, where we may expect to see poor outcomes, but we are seeing evidence of improved outcomes or resilience. It also can sometimes help us uncover groups or populations that we haven't been thinking about. Often when we're looking at health, we are creating categories or containers with regards to the groups we're looking at, and as automatically, unintentionally, when we create categories and groups, we end up excluding some individuals. So intersectionality can sometimes help us uncover the groups that we have unintentionally excluded by creating categories of people that we're trying to work with in terms of creating better health outcomes. In terms of using intersectionality in my work, I would say that often in my current work in HIV/AIDS, we are looking at the population health level, where we've created categories of groups that we say are at higher risk for living with HIV. And again, in doing that, we have unintentionally excluded some individuals. So I try to create programming that is flexible enough so that people can see themselves in our work. Therefore, we can reach them as we try to do outreach, prevention work, support work for people who are at risk or living with HIV. I think I'll stop there so that someone else can add into that.
Great. Thank you very much for that, Ruth. So, Natalie?
Hi, can you hear me?
Yes, we can.
Natalie Clarkson Squest. I just want to acknowledge that I'm in the speaking to you from the unceded territories of the Secwepemc people in the interior of British Columbia, and it's a community that I'm part of and accountable to, as well as my Métis ancestry, my mom's side, and settler ancestry on my father's. Yeah, so I think that even how we begin and consider the lands which we're on is very much about how my understanding of intersectionality is formed. Thanks to everyone for the invitation to be part of this. For me, similar to Ruth's point, I think that so much of what we do in health is about constructing people through risk boxes, trying to avoid risk, risk adverse, and I think that my work has been really about taking risk out of the individual level of the body and trying to really understand how that risk is produced structurally to our systems and policies. And you know, I do, as it was noted, I've been doing violence counseling, sexual abuse counseling for over 20 years, and all of my work there has again and again revealed that often those children and youth or families I'm working with are not able to access our services or benefit because those services are constructed in such a way that they're excluded for various structural factors. So the more policy systems in their life, the less likely that they're going to access a mainstream service. If they're, you know, a kid in care, if they've been in the criminal justice system, nobody's really paying attention to or talking about the ways that violence is actually created through policy systems. We're much more interested in speaking about their depression or whatever they're coming in the door with. So, so for me, my practice related to intersectionality is really moves from that level of the individual who walks in and is disclosing about sexual violence. The last 4 years been working at the Burnaby Youth Clinic in unceded Musqueam and Coast Salish territories. And so they're coming in for health care, but oftentimes as a result of that, they're disclosing a number of different experiences that are going on for them. And so for me, it's really important to kind of be able to see and understand how they're talking about that and how they're framed in the system. And so that's one level. And then at the level of my my work at the university is kind of looking at the policy. So my doctoral work has been in policy. I give a shout out to Daniel Grace, who I think is on the phone, who was part of a intersectionality-based policy framework with Dr. Olena Hankivsky that I was a part of. And I really wanted to bring to that how Indigenous people's ideas and ways of knowing have been you know, always intersectional and holistic, and that a lot of what colonialism did was kind of break apart those pieces. So I think a lot of what I'm trying to do is draw attention to that kind of work. So I kind of see it as how oppression is produced structurally, but experienced and resisted individually. So for me, intersectionality is also very rooted in my activism and the kinds of work I might do at the level of violence that might be also violence on the land, so looking at the impact of mining in certain communities and how that affects the bodies of children, youth, and families that I work with. Yeah, so I'm going to speak, I'll stop there because I can share more later, and but I guess the final piece for me is just to share that when my twins were born at Children's Hospital, where I was the youth health consultant at the time, the box had been ticked that they were Indigenous children, that I was a solo parent, that I was of Indigenous ancestry, and they sent the social worker to my room. And I actually knew her, and I trained her. I said, oh, hi. I'll not name her now. And I said, why are you here? And that's because the box was ticked. So the ways that this stuff writes risk right onto our bodies, that was not a service I requested, and right away you can see how that was race, class, gendered, and I had the ability to resist that because I actually had a pretty, you know, position there that I was actually trying to change curriculum to reflect this. So I think that these are very lived experiences, and if we listen to those we work with, they will tell us about how policy has actually created and shaped their access to health and the inequities as well. So thank you and I'll stop there and let our next speaker go. Thanks, Jam.
Thank you so much, Natalie. Samiya, you're up next.
All right. Good afternoon, everybody. My name is Sami Asti. Thank you, Natalie and Ruth, for the wonderful start to this conversation, and specifically for acknowledging that we are on Indigenous land. And I will just carry on from that. Being an immigrant woman, a Black woman, a Muslim woman, a visibly Muslim woman, and living that in those intersections of identity, I use intersectionality as a framework to help understand how factors such as race, gender, culture, religion, language, and ethnicity, sexuality, sexual orientation, all interact to affect and impact the health and well-being of individuals and communities, and how combined these factors are actually the sum is greater than so it's beyond 1 + 1 = 2, it's 1 + 1 = 20 perhaps or more. So how all these factors interact and combine to actually add to the systems of oppression that the communities we serve, specifically in public health, how all these systems of oppression affect their lives. And from a practice point of view, my colleagues and I do trainings, as Sumi mentioned in the introduction, across the province, particularly to public health practitioners in the areas of program and policy planning, implementation, and evaluation. And as we do those trainings, and specifically around the area of health equity, we invite our participants to identify and reflect on these multiple interlocking identities of their population that they are trying to serve, and beyond examining it, to act on these systems. So to recognize their own privilege and power, and to understand how those systems of privilege and power further increase in health inequities. So again, as I was just mentioning, it's beyond recognizing. So creating awareness, learning is a starting point, and then what do you do with that knowledge, and how do you apply it at an individual level, at an organization level, and then hopefully what changes can you bring at a systems level. Thank you.
Great. Thank you so much for all three of you for getting us started. As I heard all of you speak, I want to join in thanking you for acknowledging the Indigenous lands we're on. Ruth, you spoke about paradoxes, and Natalie and Ruth, you both talked about resilience and resistance, which is something which I'd like us to pick up on as we continue into other conversations. And Samiya, you talked about, for us as individuals and as practitioners, intervening in the lives of a wide range of communities and individuals, how we actually position ourselves in those conversations. So thank you. We're now going to move on to our second question. And again, a reminder that you can start to send in comments and questions via the chat box. So our second question is around this question of power. So when we started our conversation today, I mentioned that intersectionality has an explicit focus on systems of power, and I think in our introductions, our speakers have sort of reinforced that idea. So in many ways, when we talk about social locations comprised of our gender, sex, sexual orientation, class position, race, and the wide range, it's clear that we cannot separate our social locations from the very social systems and the social processes which actually create those identities. So how, as an approach, does intersectionality actually help us understand systems of power? And again, specifically thinking about this in terms of health equity, health inequalities, and understanding a wide range of social determinants of health and health inequalities. This time, I'm going to ask Natalie to get us started, and we'll go to Samiya and then Ruth.
Hi again. So for me, the awareness power and how it's always operating in the background is, depending on our locations or understanding, maybe obvious or not so obvious. And I know you used an Audre Lorde quote to start us, and there's two that I like to hold up related to this that help reveal that. And one is Lee Miracle, amazing Indigenous writer and scholar, who talks about this in her writing. And so lots of times the roots of this exist in poetry or activism. And Audre Lorde says that at one time she was talking to her mom about something that happened at school, and something that revealed the system wasn't fair, where she wasn't elected. And her mom says to her, "See, the bird forgets, but the trap doesn't. I warned you, child. Why you worry your head so much over fair or not fair? Just do what is for you to do and let the rest take care of themselves." And so for me, both Lee Miracle, Audre Lorde, in Lee Miracle's quote, she talked about, when we lived in a glass house, we could both see. It required a mere shattering of the glass. I thought that night when you smashed my face that I'd succeeded in breaking the glass house. When glass breaks, someone gets cut. I did not mind being the one because I thought I'd swung the hammer that broke the glass, but you built another wall. I dare not tamper with steel. So lots of times, both of these things reveal to me how I see power always moving and operating in the lives of Indigenous children, youth, and families I work with, racialized youth. And sometimes I'm helping them to see that frame, what's in the background, and other times they live it very much. So, for example, in my first job out of my BSW was at doing addictions work at Peak House, the youth addictions place. And every single one of the youth that was there was overrepresentation of Indigenous youth, racialized youth, and there was no acknowledgement of why people use substances. It was, single issue system. They were left from their small communities to come to the corner at that time of Main and Broadway in East Vancouver, and would leave sometimes in the middle of the night. And I received a lot of disclosures there when I was working, and that really, that's when I went back to do my master's and really focus on violence. But I really wanted to understand what creates these issues that we think we are supposed to intervene in. And so I guess when you come back to power, because I've done so much of my work in the area of sexual abuse and violence, and as you mentioned, a lot of my work right now is looking at trauma-informed practice. But also really I just want to say that how intersectionality changes how I look at trauma-informed practice, if I could just use that as an example, is that I actually talk about the danger of trauma-informed practice. If we're reproducing white Western ways of trauma that don't acknowledge the ways that trauma can actually create more risk in bodies and more diagnoses, that's not the kind of trauma I'm interested in. If it's a decolonial, intersectional trauma-informed practice that really understands power, because sexual abuse is about power, and if that is in any way replicated in our systems and our policies, then we are actually doing harm and violence. So for me, this is so concrete and something that I move in all the time, that trying to name the systems of power and actually help them to see what was happening. So I'll close here, but I just found in my last research project with a youth addictions program, they wanted me to do analysis of how gender programming was important, and I refused. I said, this is not just about gender. And again, those youth I interviewed over 2 years, every one of them had to be criminalized before they could get help. And they've had multiple placements. And nobody had ever acknowledged the violence of the system in their lives. The system wants to start with their depression or this presenting problem. And I think we have to always attend to power, or actually we are doing more harm in our systems. So this is obviously something I'm really passionate about and live it in my practice, not just my writing. So thank you.
Thanks very much, Natalie. So just before we move on to Samiya, Natalie, you just mentioned the importance. So you talked about the danger of trauma-informed practice if it reproduces Western ways of thinking and knowing. So what would an example of a decolonial intersectional practice look like in the context of trauma-informed practice? I heard you speak specifically about in your work naming the systems and when you work with colleagues and with communities. Can you give us like maybe one or two other examples of what that would look like?
Yes, absolutely, and I'm happy to send out a couple of couple of resources around that as well, where I have some very specific questions that you can go through around that. But I think one of the things that trauma-informed practice is trying to do is not reproduce harm and allow people to access and benefit from our services, at the very least. So for me, having an awareness of power is implicit in that. And so understanding even whose trauma theory am I replicating? If you cannot define your trauma definition of trauma, what you consider as the acts of violence that are considered under that. So for me, it starts with ourselves. So each practitioner should really interrogate who they are and their own understandings and even these frameworks. I mean, that's great that there's all these trauma-informed practice frameworks out there. Do they recognize, you know, intergenerational violence? Do they understand racism, daily acts of triggering? So for many of the people I work with, there's another piece, just understanding that even accessing our service can be a trigger. And so to be trauma-informed from an intersectional way is to understand that the person who's coming to see me might not be experiencing harm related to even their sexual abuse or their cancer diagnosis, that in fact it's about the racism they encountered at, you know, on the phone or in the waiting room. So for me, it's very reflexive. Reflexivity is a principle of that, meaning we really have to situate and interrogate the definitions and not just take these new flavors of the month, whatever they may be, you know, and really actually understand its roots like we've done here, intersectionality, read deeply, read those that might not be cited often, but who actually are, the, you know, the pieces around that. So for me, that's really an important piece, is how we define it and then how we name, because power is so integral to most acts of violence and trauma. Then how could we have a trauma-informed practice that isn't intersectional? To me is just implicit in that. So thanks for that question. I hope that, I'm happy to put in the chat a couple links that might be helpful as well.
Great, thank you so much for that, Natalie. And yes, the links would be very helpful. Right, so Samiya, you're up next, and we're on the question number 2, how does intersectionality help us understand systems of power?
Thanks, May. So power relations exist along the lines of gender, race, class, and as we were talking about defining intersectionality, we talked about how all these things are mutually reinforcing, and they create the systems that we know as racism, patriarchy, classism, heterosexism. So what happens is sometimes if we are not cognizant, and I'm going to you know, go from some of the points that Natalie was just talking about, if we're not aware of who has the power and where does the power lay, what happens is these narratives then gets distorted. So I'll give you a quick example. So we often talk about the pay gap, and people like rhyme off stats such as for every $1 a man gets paid, a woman gets paid 73 cents or 73.5 cents. But which women are we talking about? Are we talking about white women, or are we talking about black and indigenous women? Are we talking about women of color and racialized women? A similar thing, like, so as Canadians, when we were all celebrating that the Canadian cabinet, gender parity was made, the reality of not having a single black person in that cabinet meant as a black woman, I couldn't really celebrate that gender parity has been achieved. So in these discourses and as we are talking about these things, we have to also realize, so I'm going to bring it back now to public health, and I'm going to talk about maybe who owns the power, who has power in research, who has power in evidence generation and replication and knowledge translation, whose knowledge is a worthy knowledge to be shared and replicated. So as Natalie was saying, when people use terms like trauma-informed practice, or even use health equity, is it a check mark, or is there a reflective practice? Have people actually took the time to understand what does it mean to work to address health inequities from the perspective of those people who are facing health inequities, living those lives, Or is it a checkpoint where you go through a list and you're like, hey, now we have a diversity person, now we have a health equity specialist, we've hired one in our health unit, so the rest of our 400 staff don't have to worry about health equity anymore, right? So that is power. So when we bring in someone, how much power are we providing them? When we say that we are implementing a new process, when we put words like addressing health inequities or working towards health equity in our vision and mission statement as organizations, what does that mean? How much power are we putting behind those words, and how much work are we willing and resources are we willing to put towards them? So when it comes to reflecting on power, those are the thoughts and ideas that need to be kind of discussed. Thank you.
Excellent. Thank you, Samiya. So, Ruth, you're up next.
Okay, thank you. When I think about intersectionality and systems of power, I think about power, both explicit demonstration of power and a power that may be hidden or implicit. I also think about the unintentional and intentional erasure of types of disparity, erasure through not naming an issue, or really trying to overly simplify the inequality that's the inequity that's taking place, or the disparity that's taking place. I think about things such as the shorthands that we sometimes use when talking in health, where we don't make it explicit that poverty is gendered, that poverty is racialized. I think about the fact that we often don't, at the outset, when we're looking at a particular health issue, automatically say what is happening for Indigenous communities, what is happening for communities of color, what is happening for women, what is happening for LGBTQ folks with this particular health issue. When I am thinking about systems of power, I also think it's important that we think about where we often want to intervene in health. Both Natalie, I think in her examples and in her speaking to this, made it very explicit that we often focus on interventions that are about the individual as opposed to creating interventions that are about changing our systems for how we address health disparity and inequity. And you know, in our focus on social determinants, I think we can see this very clearly. When I'm doing work here with staff at Aqua, we try to look at multiple social determinants as we are working with folks on deciding what it is they need to be addressed in terms of improving their health. Though we are focused on HIV/AIDS, we certainly don't do that clinical care piece, but often on the kind of frontline level, we're worried about individuals and their housing, their food security, and their sense of inclusion or belonging in the community as having a pretty detrimental impact on their health outcomes, in addition to whether or not they're having their medical needs related to HIV and AIDS addressed. So often we ask people on this kind of frontline individual level to hop through, you know, multiple, hoops or jump over multiple barriers to get these things addressed in many places. And even often when we come to finally getting together, you know, getting to the level of we need a community hub, still we're not really thinking up, you know, higher up about what are the systems that are creating this disparity for individuals and creating crisis in their lives. I think that when we look at how all of these systems of oppression are reinforcing or mitigating one another, then we have to explicitly address power in how we go about doing our work on a systems level and not just the individual level.
Great. Thank you for that, Ruth. So just we talked about the importance of intervening at the systems level. And in the HIV world, what would that look like?
I think we've seen a pretty great message recently on World AIDS Day, where there were multiple members of Parliament speaking on Parliament Hill about the need in terms of moving forward in our prevention and support work, not just looking at the systems that deliver care to individuals living with HIV, but looking at how our criminal justice system through HIV criminalization creates risk for individuals in terms of healthy outcomes related to HIV, in terms of criminalizing people for non-disclosure as opposed to using a public health focus to address stigma that makes it hard for people to access testing and to disclose their status. If we look at the other systems, the fact that we don't have national pharmacare to improve these outcomes, and the fact that perhaps having that would not only improve outcomes with regards to people living or impacted by HIV, but for people who have other very specific medical health concerns, then we're thinking at that systems level. What do we do in terms of the overrepresentation of Black and Indigenous bodies in our prison system and how that impacts health? What do we look at in terms of how we settle and support newcomers, whether they be immigrants or refugees, and how that influences people's health outcomes? So really looking at that systems level rather than just the, when it comes to HIV/AIDS, I can say a presenting health issue. Yes?
Excellent. Thank you very much. So we're now going to move to our third question. And I think our presenters so far have made reference to health inequities in Canada, and I've heard some very specific examples named today. So there's a little bit of overlap between this question and the previous one, but we wanted just to focus very explicitly on the question of how can intersectionality help public health specifically to respond better to health inequities and health inequalities. And Ruth, one of the examples you talked about was the shorthands around poverty, and you noted that poverty is gendered and racialized, amongst other things. In my experience, when I talk to a lot of people in public health, that is not necessarily a lens which is being consistently and explicitly brought in. So how, looking at health inequities, can intersectionality help us better respond? And this time we are going to get started with, how about we get started with Samiya, Ruth, and then we'll close this question with Natalie.
Perfect. So I think public health actually is a perfect fit for this framework of using intersectionality. As a practice, we are already thinking about improving health and wellness at a population level. We are working on reducing health inequities. Public health has the advantage of operating from an upstream root cause and working on the root causes of these inequities, and knowing that health disparities go beyond the personal choices of the individual, and that they are shaped by social, political, economical, and historical factors. So this framework, therefore, provides an opportunity to plan, implement, and evaluate both programs and policies, and for people to have an opportunity to examine the current and historical context of those we serve. So often in our training, my colleague Kim Bergeron, who happens to be in this call today, I've seen her name earlier, and I often ask the question, when we are designing a program, are we designing a program to fit the individual needs of those we serve, or are we trying to fit the individuals in an existing pre-designed program that we bring in? So we often, especially from an international development point of view, we often, and this is, of course, is the case also in many communities, we often refer to the concept of parachuting in solutions into a community without really taking into consideration who are we talking about and who is at the central of our programming versus who's the peripheral. We often talk about a middle-class white being the center of our programming and then everything else being the exception. So I think it's perhaps revolutionary to think about those who are most marginalized and pushed out of the center to do a little bit of a reverse engineering and to actually put the center of our programming and our designing both at a policy level and the program level to start with those who are most in need of our programming when we are addressing health inequities and start from there. So that would be my answer.
Thanks for that, Samiya. We're going to go on to Ruth and then Natalie.
Okay. I think that as a framework or perspective, intersectionality enables anyone with kind of a work that's rooted or focused into public health to really try and identify what's in the gap, for lack of a better way of putting it. What are we not surfacing? Who are we not naming? What issue that really is at the heart of the matter are we really having a hard time identifying? And I think about, as we're having our discussions and going about doing our work, when we say or hear things such as, you can't talk about that here, they are really hard to reach, hidden populations, we haven't found that to be a common need, or it's not within our scope of practice or our scope of care. These kinds of phrases. I think that when we use community-based methods, when we are flexible enough to allow knowledge that isn't from the academy, or knowledge that we consider, we think about what we consider legitimate knowledge would be a better way of putting that. Then we start to surface other kind of constellations of need, or how we need to become more flexible systems to allow people to advocate for what they need in terms of their own wellness. So going to communities, asking them what the boundaries of their community are, asking them to identify what it is that they need prior to designing any form of intervention. I think these are the ways that we respond more appropriately to health inequities in Canada.
Excellent. Thank you for that, Ruth. Now on to you, Natalie.
Barking. Also very intersectional. Sorry, working from home today. Yeah, I'd like to follow up on that. I completely agree that one of the ways that we can do this is ensuring we are centering, funding, research, policy development that is led by communities that we provide our collaboration or support to that kind of work. So for example, myself and my friend scholar Sarah Hunt were invited to be a part of a research project with the National Indigenous Youth Council on HIV and AIDS and the Canadian Aboriginal AIDS Network. And the project was actually started by Indigenous youth from across Canada who wanted to talk to other Indigenous youth about how they felt about the term at risk and what other languages might be used to talk about their lives and identities. And we used arts-based methods. We supported them in doing the research. And I think it revealed, again, how much they felt they had to go through these doorways of risk to even access service, and how much they did not want to be that. So we're actually have just been producing, they want stuff for policymakers as well as practitioners, some one-pagers, two-pagers coming out of that that kind of reflects that. And so I think it's recognizing that we really need to shift our approach. For example, another example would be we often fund best practices, or we invest our funds there, when really the research shows in lots of cases those practices don't work for indigenized, racialized immigrant bodies. That, if I bring up trauma again as an example, that we need to be situating the kinds of work that's happening in communities. So like Indigenous girls groups that I've been a part of, those are spaces that youth want to talk about issues of violence, access health care. So, looking at those intersections of rural, we know that our rural regions, have health disadvantage. What is that about, and what kinds of programs would shift those, or maybe are happening in communities already? And lots of times these might be small programs, or they've been going for a while, and they're not, they have one-time funding or second-time funding. So I think we really need to shift our focus in so many ways to address the kinds of things that we can do to respond to these inequities that are actually being done in our communities. The other example I would say, for those that are interested in how you kind of take this, is I was a part of, again, where I was at UBC, I was on the sexual violence policy development or task, where we were a group brought together with Sarah Hunt and others. And I think we are one of the only that made that policy intersectional. And I wrote the piece on responding to disclosures and how that needs to be intersectional. For me, this is just so, it is at the level of practice, but it is also at the level of policy, and these need to be in conversation with each other. So I think we need to share examples that, and even in our consultations there, we held them over and over again with, students who came through many different intersectional spaces to talk about how even their needs, or even how safety is defined intersectionally. And I think if we're not listening or centering those voices and providing the kinds of supports, then we're going to keep replicating, best practices, which in so many cases are not meeting the needs and creating more harm. So I think I'll finish there.
Great. Thank you for that. As a reminder to our participants, you can start sending your questions by the chat box. We're going to do one more round of questions with our presenters and then take your questions. One of the things that's come up during today's conversation, and which I hear all the time, is this idea of complexity, and that maybe if we understand the very fundamental idea behind intersectionality, which is that as individuals and communities, we are multifaceted and we're interacting with multiple social systems and processes. We get that at a sort of a head level, but when it comes to the practicalities of it, it starts to, for some, feel very complicated, and so we then go back to very simple ways of working. How do we resist the temptation of going back to simple solutions when we know that intersectionality tells us to remain focused on the complexity? And also, why is this an important thing to keep in mind? This time we're going to start with Natalie. How about you get us started, and we'll do Natalie, Ruth, and Samiya.
So this is something I teach a lot. Volunteers, victim service workers, social work, and so for me, that's, if I can't talk about the complexity of intersectionality in a way that it's accessible, and so that's, I guess that's the piece, is it's very, my children understand this. I remember when one of my twins asked me, trying to understand the marker that existed around missing and murdered Indigenous women, that the friendship center space he was accessing, and he was like, Mom, can 2 or 3 things come together? Like, why does this happen to Indigenous women? And could it happen to you? And then we talk about whiteness, and he said, what about Two-Spirit and boys? Like, this is at 6. So I'm like, okay, he's already figuring out, why does this happen here, and how does this get taken up? So for me, I like to teach, our assessment, all of us often, whatever we are, we're filling out forms, we're creating the kinds of ways that people can actually even access our service. And so I think right from that point is thinking about who are the individuals accessing, how do they identify themselves, how do I locate myself in that, so starting at that reflexive individual level. Oh goodness, my dog. Which structural factors of power and privilege impact their lives? Like how, and I always ask, how are they resisting these as well? That's one way that I move away from risk discourse right away, is I'm right away trying to center, even where they've experienced violence, colonialism, harm, what are the strengths, resistance, or what Wisner would call survivance that's present? What are the ways that is produced? So for example, at the structural level, many people are referred to me for health issues of eating disorders or self-harming or suicidality. And yet those are very much smart survival strategies that they created to survive the violence. And so how I even name or engage with those health issues that they present with is really important. So I think it has to be at the individual assessment level or health practice. So when I was running an agency, I changed our reports. And I said, I need you to fill this part out. I had the power to do that. So I'm like, okay, if you can't identify the strength, resistance, complexity of this person, I'm not interested in assessment forms that replicate these normative structures. Then looking at the level of representation, like what discourses exist about this person, family, in the media, schools, agency, how are they resisting that in their communities, on their bodies? And then I'm really interested in what are the intersections of policies that are coming together already within the individual or family. So are they with education, justice, mental health? So are they, already on their 3rd school? Is this their 6th placement? And if I see those as policy systems coming in to do harm in their life, not something that's wrong at the individual level or family level. Always situating the person within the context of colonialism, poverty, discrimination. So, what nation are they in? What's the understanding or history there of when did the residential school close there? When did their people come to this country? I mean, for me, it has to be that complex. But also not to look for, we need diversity, intersectional approaches within all of our communities. Indigenous youth aren't the same across these countries, the languages, urban, rural, so we need a complexity there. And I guess the final piece is, in my referral or advocacy, I'm always supporting the use of local resources, capacity, strength, and accountable to social justice or activism, kind of how am I taking that up in my work, because that is so key in intersectionality as well. So that's kind of an example, I guess, of, so for me, and I think someone said this earlier, rather than looking at where we're doing well in our programs, I want to look at who we're failing and why we're failing that. Case studies, whatever you want to call it, but if there's one person who's been referred 4 times and isn't showing up, that's what resulted in me developing It's a Girl thing and doing this work in the community. So for me, the most innovative, interesting work is about following where we're creating harm or we're creating barriers. And I'm happy, again, to share some of those tools or strategies to work it through from all those levels, but I think we have to be doing that, because otherwise we're continuing to do the same thing over and over again, and that's not working. Thank you.
Excellent. Thanks for that, Natalie. And Ruth and then Samiya for this question. And we're talking about complexity and intersectionality. How do we stay focused?
Okay. So for me, I was thinking very much of, Natalie, what you just mentioned about looking at where we keep on running into barriers, where we keep on failing. Looking at the areas where we see unmet need. Something has to change for us to be able to do good work with people, or something has, we can very clearly see something has to change for us to create some sort of social transformation or liberation. You know, I've heard these called or identified as moments of intersectional recognition. You know, and you know, being wary as we go about doing our work if we ever come across a sentiment about we treat everyone the same. You know, putting that out there as a positive or a good thing. For me, I think that something that's very important in terms of looking at this issue, you know, looking at complexity, is how much time we are able to dedicate to the more, you know, difficult or challenging aspects of the work we're trying to do, whatever it is that we are trying to accomplish. Do we have time for process that allows us to listen carefully, listen intently, and then ask questions that allow us to respond appropriately, not with what we assume is going to be the appropriate solution for the situation? How are we going to foster conditions for action to take place? And numerous people might be the actors in that. When we're looking at complexity, I think it's important to think about time as well. There may be ways in which individuals or groups are experiencing barriers, and there may be strategies that they are showing us if we have the time. If we have the time to be present with them, that show us what we need to do. They are likely to be able to lead the way. In that very same vein, who gets to do the work and who gets to be the actor? I think about in HIV/AIDS work, the use of peers and how sometimes that gets misconstrued as individuals living with HIV acting only as advisors or perhaps as volunteers in the movement towards better health outcomes for people living with HIV and in terms of trying to make sure that individuals are not vulnerable to HIV. There could be individuals living with HIV involved as leaders in many different ways within the sector, and it often ends up being simplified down to advisory as opposed to paid staff, executive directors, individuals who have chosen to disclose their HIV status and be champions for the movement, and really thinking about who gets to do what kind of work when it comes to public health and health equity, and where they get to be located.
Great. Thank you for that response, Ruth. Samiya, off to you. As a reminder to our participants, you can start to send in your questions via the chat. If you are participating today by phone only, you can respond to the email which you got today from Anna McNeil, and we'll take your questions that way. Thank you. Samiya, off to you.
Yeah. So I think it's about the question around staying focused within the complexity of intersectionality, and I'm going to add to what Ruth was just talking about in terms of taking the time in spending the resources and the energy to, I would say, more than even intendedly, more than just listening or carefully listening to, being mindful of what you're hearing, being willing to change your perspective. And in our training, we often talk about discomfort as a tool for learning. Being okay with discomfort, sitting in that discomfort for a minute, recognizing if feelings of guilt or anger come to surface, then that's good. Use that as an opportunity to learn. And at the end of the day, notice or know that for many of us, where we have the privilege of working in this area, choosing to spend time thinking and reflecting on these issues, while most of the communities, individuals, and the populations we serve live in this discomfort, and they don't have the option to opt in and opt out of their lived experiences. So while we say we might use words like complex, difficult to discuss, difficult to find solution to, these are the lived realities of people. So spend the time. It's okay. It's difficult, yes, but if we spend the time and energy to do this work, then it's going to get done. Otherwise, as you were mentioning, Sami, it's easier to just say, yes, we serve all women. It doesn't matter. These are programs for women, so we're not going to worry about who comes through the door. Yeah.
Excellent. I'd like to thank all three of you for your responses to our previous 4 questions. It's raised a lot of interesting things for me, but before we go there, I would now like to take some participant questions. So as a reminder, you can send in your questions by the chat box, or if you're participating by phone only, you can do so by responding to the email you received about 2 hours ago from Anna McNeil, and we'll take your questions that way. We're going to get started here. So there's a question from a participant around the tools which we can use to operationalize intersectionality. Our presenters have shared some resources, which I think is a very good starting place, and the links are on the slide decks which you received. But I'm wondering, Ruth, Samiya, Natalie, any tools that you'd like to share with our participants?
Hi, it's Natalie. I don't know if anyone else is unmuting. I don't know if I can type it into here, but I'll upload them both to my academia.edu. So one of the things I've developed in my teaching is a reflexivity tool that I share. So again, it's something that takes you through the kinds of questions that I think are important. As well, I think you put the link up there for the intersectionality-based policy tool. That piece has some principles that I think are really important to go through, so I think that link. But I think starting with grounding in our own experiences, and then the kinds of things that we can be doing in our teaching or practice, and I see some of the questions here that people have put, that maybe we can develop a resource list of some others. I know in my own teaching I've used different examples, have some great reading lists as well. So I think there might be some ways that we can share this and make it very practical so that it's helpful. So yeah, no, I'm happy to kind of try and create a link or be able to upload some of those more community-based when I'm doing my teaching about this in community. So I haven't published them per se because they're really about the way I manifest this in the work, but I think they are important to share. So I'm happy to provide those. And I think there's a lot of great work being done. We don't have to replicate it as well. Thanks. I'll pause out there.
Thanks, Natalie. Ruth, Samiya, any tools, resources you'd like to share with our participants?
I have suggestions. I wouldn't call them necessarily tools or resources, but I think about working in coalition with marginalized groups and individuals from the outset of any public health project or endeavor, organizing with those communities that are most affected or most impacted by an issue from the outset to develop what the process and the agenda will be. And in doing that work, think about how I think that everything that Natalie said about risk is brilliant. I also think about how often, and when we're doing our work, we the conditions of our work often shape it that we need to think about risk mitigation in terms of how we go about doing our work all of the time. And I think that being intentional about how we assume risk because of often people who are experiencing multiple forms of marginalization are existing in a consistently risky environment. How do we actually go about being deliberate and assuming some risk to create some safety or some venue for individuals to actually access supports from us? By assuming risk, we can sometimes make our programming more flexible, more accessible for people. So unfortunately, I don't think those are highly structured tools, but there are some suggestions I have.
Thanks for that.
I was just going to add that we have a resource that we created specifically, not necessarily on intersectionality, but in addressing health inequities. That it's an extensive resource that basically it's a list of about 15 resources that I'll be happy to share. Also, a few exercises that we typically include in our training that provide an opportunity for self-reflection. Another tool that I might mention is the Health Equity Impact Assessment tool, although that tool itself sometimes is limiting on focusing on a single issue. But what I often focus on is on the step, I believe it's step number 3, which is at the time of a designing of or planning a program, spending some time thinking about unintended positive and negative consequences of any work that you might be doing with any community. And so just putting in some dedicated time to reflect on what are you doing and what impacts your actions might have on the people you're trying to serve.
Great. Thank you all for those suggestions. We're also dropping in some links in the chat box, and if people on the line have things they'd like to share, please do so too. So we have a couple of other questions here. Let's see. So there's a question which is related to children needing protection. So one of our participants says, I found in social work practice with children needing protection that they often couldn't access mental health services until they had done something detrimental to self, such as committing a crime, assaulting a family member, or suicide attempt, or drug overdose. The aforementioned can stigmatize already stigmatized youth further. How do you destigmatize and demarginalize with preventative and positive support services to children and youth? I think some of the things, the examples you just shared in response to the previous question start to get at some of that. Ruth, you talked about the importance of working with communities at the outset. Sami talked about discomforts, creating some sense of safety. Do you want to add any other examples of how we can do that? And the question is, how do you destigmatize and demarginalize? Any comments about the question itself?
Maybe I'll follow up on what was said. I really believe this is important of where we start and the really importance of right from the beginning involving communities, including in particular around, like, for example, child welfare, listening to and centering the voices of children and youth in those spaces, and looking at programs and approaches that are doing that. And so I know that's part of my work right now is interviewing Indigenous counselors and social workers in Secwepemc territory to see to what degree they're actually engaging with Secwepemc land-based, not pan-Indigenous, but what are the ways that their approaches, what are the kinds of programs they say are working, how are they using their traditional teachings or storytelling or not, even if they're trained in a Western-framed way. And so I know there's lots of examples that are coming out. Rebecca Jules, a friend of mine, finished her master's recently looking at Secwepemc child welfare approaches. Sandrina DeFinney's work on the island, kinship. We actually need to turn away from all this harm because we know this isn't working. I mean, you could just follow Mary-Ellen Turpel's reports that have been produced. You're right. This is exactly what I see happening is in order to access service, they're already criminalized. But, I mean, we've actually added to their risk just to even be able to access service. So we know the kinds of things that are working, like that, girls groups in community, Indigenous girls groups, racialized girls groups. It's a Girl Thing was really the girls group I developed because it was like all these young women who weren't accessing the agency I was working at because they had to come through all these things. You couldn't be in a sexual abuse group unless, if you were using substances. You couldn't be here. You couldn't be there. We create so many barriers. So until they're actually mandated to some of these programs, they're not accessing help. So we actually need to turn away from that and try to center the kind of work that's being done and is being done that's working and give some space to that. Unfortunately, most of our systems reproduce the same things over and over, and someone said that we serve everyone or one size fits all, no cookie cutter approaches. Like, I love the complexity of this work and I know that it can be done. And so I think it's just getting other people excited and saying, okay, what can I be doing different? Where do I need to turn my gaze so that I'm not part of this problem?
Mm-hmm.
Thanks for that, Natalie. Any of our other presenters want to respond to that?
I would just use a personal example in that I have a child who has a learning disability, and I think about, for myself as an individual who actually had some training in the early years and would do the psychometric assessments that were needed to identify a learning disability, how many times I had to advocate and say that I actually need my child to be assessed because of, in this case, I do actually think it would be helpful before the system would allow for him to be assessed, and how much time was wasted in the interim where supports that were specific to the learning disability could have been engaged. And I think of myself with all my privilege and how many times I had to come forward and advocate for that to happen. And finally, when a crisis happened, I suppose a flag went up where finally I could access systems. And I think of individuals who didn't have access to the language and the skills building experiences I had in terms of employment would have had trying to get that done if they thought it was helpful for their child. I am the first person to say that children being identified can also be highly problematic and create horrible outcomes in terms of well-being for a child because of the power of labels. We intentionally create systems for particular levels of need and wait for things to become escalated to that point before people can get the help that they want to get. This is, I think that it's been identified by Natalie. I think it's also been identified by Samiya that this creates more harm in the long run.
Excellent. Thank you all for those responses. So we're just going to go to our final question for today's conversation. And as I said when we started today's conversation, we really framed this as an introduction to intersectionality, knowing that we're coming in here from very different points and that this for us as an organization is only, the beginning. We just happen somewhere in the journey in terms of learning about intersectionality. And we wanted to get a sense from our presenters. You've raised a lot of pertinent issues today. What are the conversations on intersectionality do we need to be having? And for you participants, what has this raised for you? So in the chat box, let us know, what has this raised for you? What are the questions do you have? And our last question, how about I'll go back to you, Ruth, and then Natalie, and we'll close with Samiya.
I would say, if I look here and I say, what other conversations do we need to be having? I think it would be, one basic one would be, why not? Why would you not be having a conversation about intersectionality. We have a very broad, we're starting from a very broad definition of health that encompasses not only health, but well-being. We throw around terms such as autonomy. If we're not having a conversation about intersectionality, who are we serving? I think implicitly, we're serving those that it's easiest for us to serve. Ultimately, we're not really shifting anything towards social justice, social transformation, or liberation. If it's really simple, if it's really easy, I suspect that we're not doing that kind of work. So I think that we would have to ask ourselves why we wouldn't want to be engaging in a holistic, in an intersectional way. And that's about it for me right now.
Thanks for that, Ruth. Natalie, what other conversations on intersectionality do we need to be having?
I think I've pointed to some of those. So sometimes we, even in our desire to deal with complexity, whether that's addressing social inequalities or addressing health equity or those pieces, the new thing comes along and it gets added in without engaging with that with the complex way it's needed. And so I think that any time that there's a mandate or we're told in our practice, okay, this is what we're doing now, I hope that people do the work. Why not? As was just said, for example, trauma-informed practice. Sometimes I say danger of trauma-informed practice ahead. Sometimes I say widening the frame. What would an Indigenous, decolonial, intersectional practice be? So I think that we need to, I agree, why not? As well, make sure that in your writing, talking about it, engagement, that you trace those complex roots. That if I could take it back to the first slide, I think if everyone leaves here and reads something that's really emerged out of that activism, who do you know, what don't you know in terms of some of the work that was even done between, whether it's the Combahee Collective, Audre Lorde, Women of Red Nations, within disabilities, the alignments between, the American Indian Movement and Black Panthers, et cetera. Like, I think there's lots of complexity that you really need to to make sure we're not replicating, because I think some of the dangers of mainstreaming intersectionality, I guess, and there's stuff written on this in Europe and others, is that we ignore its roots in, Black feminist scholarship and other Indigenous scholars and those places. So make sure, don't take the easy route even in your citation and or teaching or thinking about it. Have your students or people at your office or yourself read the poetry, read the complexity, find the Sojourner Truth piece. So I think that's, if I could take us back to where we started, it would be, that's the conversation we need to keep having so that even things like this, webinars, don't become ways that we actually move further away from those roots of activism. So maybe think about your own activism in connection to intersectionality and how you'll define it and whose voice you'll center when you're doing that. Thank you.
Great. Thank you, Natalie. And Samiya, you're up next.
So I think just to add to what my co-presenters were just mentioning, I would say I would name the danger of tokenism and saying and using some of these terminologies just because they are there. So thinking about tokenism versus creating an opportunity for power sharing, recognizing whose context are we using, whose vantage point are we looking from, and are we deviating from the norm, like how we typically plan programs and policies, and who is at the center. I would go back to the idea of knowledge generation and evidence generation, and whose knowledge is being considered worthy. So beyond naming and understanding these terminologies, what are we doing about it? So once we had an opportunity to reflect and understand the situation and had conversations with our communities, what actions are we taking, or is it enough just to say, now we know about intersectionality, now we know that, certain segments of our populations are unjustly and unproportionately and suffering from health inequities, and then what do we do with that? So I'm going to definitely add to what Natalie was saying. This is where the social activism comes in and social justice. It's the action that follows the understanding.
Great. Thank you all. Thanks to all three of you for those very insightful comments. We're just at 2:30, so we have reached the end of today's presentation. I'd like to thank our presenters, Samiya, Ruth, and Natalie, for joining us here today. To Val Morrison, who is on the line, Anna McNeil, who ensured that our webinar today went smoothly, and to all our participants for joining in today. I think just in conclusion, intersectionality, I think, really speaks to the particularity of our experiences, and also, again, as all the presenters have shown us, to how social systems create different experiences and outcomes. And I really love that reminder to go back and trace the roots of intersectionality and keep it grounded in its activist past. So thank you all so much for joining us today, and we will be sending out an evaluation survey, and we would love your feedback. Thanks so much, everyone, and have a great day.